that's a little bit of what our discussion could address today is, other than, licking our wounds and trying to deal with the crises, what it's done to our personal incomes or our lifestyle. Is there something that can come out of this that could improve the way we interact with each other or the way we treat patients? That's kind of how we're looking at it. And so far, that's been a good approach, because, there's a certain amount of just plain scrambling that we're all doing. But you can only scramble so long. You can only panic so long. Eventually, you get inured to that. And you say, okay, there's an old phrase called the Stockholm syndrome. I don't know if anybody's ever heard of that, which basically, when you have a captor, after a while, you get used to your captor and you start sympathizing with your captor. So, notwithstanding that Sweden is taking a different approach to the whole coronavirus epidemic, I guess there is a little parallel with Stockholm syndrome here, that it's become a fact of life, and we better figure out how to make the most of it, which is somewhat of a paradox. But the main thing I want to stress today is, I don't have a particular speech prepared. I don't have PowerPoints. I don't have a particular outline. I do have some buckets of discussion topics that I think should be as much of an open dialogue as presentation. You guys are watching the same TV shows I watch. You may hear something different. You may come from a different point of view of what you're seeing and hearing. We all read our own publications. I'm looking obviously at a more clinical topics. What does this disease mean in terms of the epidemiology and the pathophysiology of the illness? But when you get down to it, we can do an overview of the pandemic itself, at least as I've tried to read it and synthesize the macro and micro implications, the impact on multiple levels, and what are the actions and options on our part that are both reactive versus proactive. So that's the only way I know how to deal with this. And I think some of you are going to have some opinions, observations, best practices. But I'll kind of work off of my talking points. But first, maybe we could have everybody go around and do some introductions.
Yes, actually, that's a good idea.
Name an organization.
Name an organization, and do you want them, if they have a specific question, to list a question, or just name an organization? What do you prefer?
Yeah, you could certainly put some of those. I can jot some of those down, because I suspect most questions are going to fit somewhere in this fairly broad brush.
Yes, exactly. You know what?
Set of topics I have.
Let's just do name an organization, so that way.
Okay.
And what they do. So three things.
And role. Yeah.
Exactly. So what they do for the company. Okay. So let's go ahead. Everybody, please introduce yourself. Just go ahead one by one.
I'm Dory Morper. I'm a home care consultant with Home Instead Senior Care in Long Beach.
Great.
Great. Good.
Next person.
Melanie Bischoff with Helping Hands Senior Foundation.
Great, thank you.
I'm Paula Lemkiel with Belmont Village Senior Living in Orange County and San Diego.
Nice hat. Next person.
Cowboy Day.
All right, next person, please.
I'm Mike King with Attentive Homecare in San Diego.
Hi, Mike. All right, thank you. Next.
I'm Karen. Go ahead. I'm Karen Mountain. I work with Allergan, and I sell IV antibiotics for them.
Oh, great. Thanks.
Good morning. Pam McNeil with Ardent Care, Marketing Director.
Welcome, Pam.
Hello, it's Marla Zelko and Barbara Green from Fleb Express We are a mobile blood draw service.
I'm
Great.
Allison Larrick with Cognitive Care Solutions, and we are a psychotherapy group focusing on brain health. Thank you.
Thanks. Anybody?
Hi, Gemma Benson from Vision Viejo Hospice.
Welcome.
Hi, Hi, Vanessa Ford, Ramita Health, Director of Business Development.
Welcome, Vanessa.
Kathy Gertner with Above and Beyond Referral Services. I'm a placement specialist.
Welcome, Kathy. All right.
Good morning, Lori Renaud, registered nurse with Acticare Responsive in-home care.
Welcome. All right. Next person.
Colleen Cherry, Playwell Child Life. I provide psychosocial support to children of adult patients.
Great.
Vicky Silva, Alzheimer's, Orange County, helping those navigate through memory loss and dementia.
Welcome, Vicky. All right.
Derek Mannion, Alliance Elder Care Senior Service. Thank you for having me on board today.
Welcome, Derek. Anybody else?
This is Stacey Dewage with Valley View Gardens. We're a specialized memory care community. Thank you for hosting this.
Thank you.
That's Ace with Magic Touch Home Care, Client Care Manager.
Okay. All right, Rick, you're there?
Yes, Rick Davis. Good to see you all. Thank you for joining us, Dr. Vinn.
Yeah, nice to hear your voice, Rick. Haven't talked to you in a while.
Yeah.
All right, next person.
Lots of interesting stuff.
Thank you, Rick. Who's next?
Glenn Goldsmith, Administrator, New Horizons Senior Living. We offer assisted living waiver program, and we're in Stanton in Orange County.
All right, Glenn, haven't seen you in a while. Welcome.
Thank you.
I'm Lily Vinn. I'm with House Call Doctors Medical Group. I'm the Marketing and Business Development Manager.
Okay, thank you. All right, who's next?
I'll just jump in. Vicki Hines, Senior Placement, and represent Phillips Lifeline.
Okay. Next person.
Sounds like
I'll go. It's Karen Sauls. Hi, Lily again, and hello, Dr. Vinn. I'm the nurse liaison for home care assistance.
Welcome.
Nice.
Next person.
My name is Sara Ponce. I'm the community educator at Optimal Hospital.
Welcome. All right, next.
Good afternoon. I'm Celia Hansen from St. Joseph Health. I represent the Home Health and Hospice Division of St. Joe's. Thank you.
Welcome, Celia. All right, next person. Anybody else?
Maybe
All right.
sounds like we got everybody.
Looks like.
Well, welcome. I'm gratified that there was such strong interest in getting together today under what are clearly alternative circumstances relative to the face-to-face meetings I know that you're used to having. It's also gratifying to hear the diversity of attendees because one of the things I share with our clients is, as you know, House Call Doctors has been around since 2002, and we do work in both assisted living facilities and private residences. We do a lot of work with managed care clients focusing on population health. And one of the things I'm always explaining to our, I say, group clients is that part of what we do is we're in some ways conducting an orchestra. And the orchestra has a number of different instruments. And depending on the patient, the mix of instruments in the orchestra changes. And the whole idea is to coordinate that all to make good music, which is good care, creating access, continuity, safety in the home, quality of life. And so with the diversity of people we have on this call, it is clear that most of the instruments in the orchestra are well represented. In terms of sort of telling our story, on COVID. Like all of you, we started reading the stories about this virus in Wuhan, China, as we were moving through January, and looking at with some degree of quaint curiosity, like, oh, you know, another H1N1, another swine flu, another SARS, another Ebola. Wonder how this is going to play out, but not thinking at that time that it would have such dramatic and pervasive implications on not only our daily lives, but the lives of our patients and clients, the economy, which is a huge impact, on mental health. I know there was somebody on the phone that is helping with mental health. And then, of course, you know, the sheer death rate, which is, again, in debate right now as to whether it is truly higher than, quote, a flu without Theraflu, Relenza, and a vaccine. My instinct is it's still higher. The problem is it's really focused, and you've all heard this on TV. It is focused on the overcrowded and those living in overcrowded environments. It's focused on those with chronic health conditions. It seems to hit men more than it hits women. Older patients, which is really our stakeholder group by and large, clearly very difficult for that group. And
oh, something happened. We lost Dr. Vinn. Hold on.
okay, am I back now?
Yeah.
Okay, you're back. Yes.
Okay, yeah. What happened is I got an incoming call and I had to decline it. So if
All
I
right.
get an
Hold on.
interruption, that's
Before
fine.
we start again, let me mute everybody, and then make sure that everybody's muted, and then unmute yourself. Yeah, you're back.
Okay.
Okay, so go ahead.
Okay. All right. So, you know, we've gone through what I'd say is a bit of an Elizabeth Kubler-Ross pattern here. For those of you, some of you know Elizabeth Kubler-Ross is worked very well, but it's the death and dying journey, which is anger, denial, bargaining, depression, and acceptance. I think we've all, as a society, gone through that process, which is a very unusual societal phenomenon when you think about it. Almost unprecedented. But we've looked at the clinical aspects of these diseases. We have understood who are the most vulnerable, although we have had some younger, allegedly healthier people succumb. We've seen what happened in Bergamo, Italy, when the system became overwhelmed, which I think finally got everybody's attention, and certainly moved the ball down the field faster here as we started seeing that happening. The treatment issues obviously have been a bit of a football also, with the whole idea of zithromax and hydroxychloroquine showing some initial promise, but not necessarily holding up under scrutiny. I originally, when this started, I originally got an analysis secondhand from a researcher who had done a survey, and at that point there were about 55 initiatives in place, different medications under study, vaccine trials, alternative treatments such as the plasma treatment. Now I just heard 2 days ago that there are 78 different types of medication under and initiatives and vaccines under study. The real problem is that the only one that I'm hearing about consistently right now and hoping to get better news, but it's consistently, is a drug called remdesivir, which is an antiviral agent. The problem is it's in short supply. For patients that need it, it's very hard to get, even though it's shown some promising effects in the current trials. But you know, everything we're seeing out there in the community is somewhat of a supply chain problem of above and beyond the epidemiologic and Kubler-Ross concerns here. Is there enough testing? Do we have enough testing where there needs to be? Are there enough ventilators? Are the ventilators where they need to be when a surge hits in a particular community? It looks like in New York City, we ran right up against that, but we didn't go over the threshold. We certainly stressed the physician population and the clinical population in New York City. I'm on the board of the American Academy of Homecare Medicine, so I get to talk to people around the country, and I happen to be on a call with a woman who's in palliative care at Mount Sinai, and she said they're basically overwhelmed. All their most of their palliative care docs have been pulled off of house calls, and all they're doing is providing support to clinicians in ICUs, many of whom aren't even ICU physicians. There's neurologists and ophthalmologists trying to manage patients in the hospital, including patients that are end of life, and they need help with palliative care counseling for themselves as to what to tell patients or families for patients that have a poor prognosis. It's almost hard to imagine. You know, we're sitting here in the sunshine in Southern California, and we see the TV and we hear about the news and we hear the human interest stories. It has clearly been a war zone in New York City. And it was illuminating to hear someone talk about this in a different market, clinician to clinician. But when I get back to the idea of supply chains, do we have enough tests? Do we need to have the tests where they're needed? Well, you know, then we hear the president say anybody who needs a test will get it. I don't think, you know, I'm not defending him. I don't think he's purposely.
We lost you again, doctor.
Am I knocked out again, or am I still here?
You're back. Okay.
I'm back. Okay. When we say patients who need tests will get them, remember that the paradigm has been shifting as we go. The idea was, well, we're going to test people with symptoms. And then we have a thing, well, where we need to test people who have been exposed. Well, we need to test people to see if they have an illness today. Well, we need to test people to see if they have antibodies. And with each one of these paradigms, there's the question of, are the tests reliable? You know, now they've loosened up to have independent labs developing their own tests and using them. But clearly that's not generally the way we do it, at least in the United States. We have things go through the FDA, we have tests get vetted, and they have a known reliability. They're applied consistently across the population. So there's a bit of pandemonium out there, and it's not helped by the fact that whatever statement we make, and I've had the same issue inside my own group, whatever statement we make is subject to change the very next day because something in the environment has changed. That's the challenge we face here, is try to plan around something that's in such constant evolution that, you know, people, I mean, you're all in companies and people like to know what's going to happen. They like transparent communication. They like to know what's expected of them. And right now, what's expected of us and our patients is changing from day to day. In our group, we had a massive debate, not only about the safety of patients, but the safety of our clinicians, with the concept of essential businesses, you know, which are remaining open, of which we are one. But then it got down to, well, what are essential services? And a big part of our group practice has to do with preventive medicine. And a lot of those services are really not essential services. They're not sick people. So we had to pull back on those and cut our volume nearly in half to try to remain in step with sort of the standard of care in the community, that we're going to stay in business, we're going to stay open, but we need to have essential services. We have a call center in Laguna Hills with nearly 50 people working there. And yes, we could keep the center open because we were exempted under essential services. And then we began looking as the news unfolded. Well, gee, did we need to move people further apart in the office to make sure they're meeting the social distance requirements? And then we asked ourselves, is this good enough? So we started having selected people work at home. And now we have about 40 people working at home, maybe 45. And I'm sure some of you in your own companies are facing the same challenges. Some people work remotely, other people work in an office. You're not used to just sending everyone home and figuring out how they're doing their job, if they're doing their job, if their customer service levels are remaining constant. At the same time, out in the field, we've had some clinicians that have been genuine heroes. They have said, I will keep going out there, including some people who are personally at risk. We had some other people who were personally at risk from age or chronic health conditions, and they said, I'm not completely comfortable. And of course, we respected that. So we had to constantly change territories in our group to make sure that the patients that really needed service were getting seen. If there's somebody on the phone from home health or hospice, I'm sure you're facing a very similar kind of challenge. Which nurses are still in the field? Where are they going? Who is staying home? So our planning changes from day to day, depending on the environment, depending on safety issues, depending on the standard of care in the community. At the same time, we're all sitting here waiting for some prolonged shoe dropping, which to me seems to fit into three buckets. One is definitive treatment. What can be available that we know will help people that are taking a bad course in this disease? And then that begs the question, well, even if we know what it is, can we even get the medication, right? Second thing is, when will there be a vaccine? Well, you hear over and over again, it's going to take a year to a year and a half to get a vaccine. So that's a big shoe to drop. The third one is, well, honestly speaking, 50 to 60% of the population is going to be exposed and have some variant on this illness in terms of the course of disease, some with no symptoms at all, some with mild symptoms, and some on respirators and some passing away. If you get to 50 or 60% of the population exposed, you theoretically, from an epidemiologic point of view, reach a concept called herd immunity, where there's enough people resistant that even if they're exposed to the virus, they don't get the virus. And if they don't get the virus, they can't pass it on exponentially to other people. We're a long way from herd immunity. And then, of course, we're all concerned. What's interesting, and this is a little anecdote that I think is worth sharing. Early in the course of this pandemic, I have a colleague, and his roommate from medical school has a son that works for the CDC, brilliant guy. He sent out a scenario analysis about the likely numbers of deaths if we didn't do social distancing, the numbers of deaths if we did, the questions about how long social distancing and sheltering would really need to be in place to suppress this illness, and that even if we did suppress it, the likelihood of a second wave. Because honestly speaking, if we don't have herd immunity and we let up on social distancing of some sort, then we're at risk for a second wave. Now, we're already seeing some impact of that in the sort of denial, depression, denial, anger, bargaining, depression, acceptance. I'm sure if most of you are still going to the grocery store, you're starting to see a lot more people in masks in the grocery store. You're still seeing a few people that don't wear them. But 3 weeks ago, I still go to the grocery store. I didn't wear a mask. I saw hardly anybody in a mask in the grocery store. Now when I go in, not only is it less crowded, but there's 80% of the people are wearing masks. Now that's likely to have a very positive effect over time. And I think we're still at risk for a second wave. I'm optimistic enough to think that the second wave wouldn't be nearly as bad as the first wave. Number one, if something like remdesivir has more promise, hopefully there'll be some time to get it available. We may not have a vaccine by the time there's a second wave, but we may have better treatment options. We may know who should go in a respirator, who shouldn't. We may know better who has a poorer prognosis and who doesn't. Are we going to get to the Bergamo, Italy scenario and we're going to start literally rationing of who gets to a ventilator and who doesn't? So far, it doesn't look like we've had to do that. We bought ourselves enough time through the first wave of this virus that even New York City hasn't run out of respirators. And as other communities come in, we may see some focal shortages, but certainly that's almost a national movement with this defense, I think it's called the Defense Protection Act, to redirect other industries to help eliminate the ventilator shortage. And now we're seeing plans in place for cities who seem to have passed through the surge, moving their ventilators to other cities, which of course is going to reduce the need to manufacture new ventilators. The other thing that many of us are facing, including people on this call with the field-based workforce, is personal protective equipment. We've had several of our clinicians exposed to coronavirus. We have one known case of coronavirus. Fortunately, a young clinician who had relatively mild symptoms, but went through the full quarantine and is fortunately back out in the field, but wearing personal protective equipment. And actually, we have every one of our clinicians wearing masks at visits. We were able to get our hands on some face shields. So the clinicians are wearing face shields with a mask underneath them. We have broad-based protocols in our group. We're practicing social distancing other than wherever is absolutely necessary. And we are not doing physical examinations unless they're absolutely necessary, let's say to look at a decubitus or a worsening rash, or somebody who's short of breath and we have to listen to their lungs because we need to know if they have a wheeze or crackles in their lungs. We have clinicians that are wiping off their equipment before they walk into every visit. We have our clinicians are taking their temperature before they go into every visit so that we can reassure both ourselves and the patients that we're not a vector of exposure for them. We have some facilities, I don't know if it's any of the facilities on the call, who have, I guess, depending on your point of view, either have gone above and beyond being hyper secure or really going way beyond the CDC guidelines. We have one facility that will let us in if our clinicians are wearing gowns and a hairnet and shoe covers and gloves. We have other facilities that won't let us in at all. We have patients that won't let us in, and that's legitimate. But when we talk about the other buckets here, there's clearly the societal impact, the effect on all of us and our patients and our families on social isolation. Certainly in my own family, we have looked at apps like House Party. I don't know if anybody is using that, but it's a little app you can download and you can get up to 8 people on the screen and have a virtual little party and one screen. It even has games that you can play. Obviously, these things had some traction before. They have major traction now. Zoom has had record enrollments. If you see the pictures of the people in Italy, they've improvised these long sticks where they can tape their wine glass to a stick and reach out across the street and toast each other. Certainly alcohol sales are no doubt where they've never been before. But I don't know about you, but I'm looking at my list of friends on my cell phone that I talk to once in a while, and I find myself refreshing that list and going down the list and making proactive calls to people that I haven't talked to in a long time. That's a positive outcome of this illness. I think it's reminding us of the importance of the bonds we have with each other whether they're face-to-face or not face-to-face. I have a daughter that couldn't boil water, and all of a sudden she's baking cakes because she's stuck at home. She's a physician. She's working from home because she does education and risk-adjusted coding. But all of a sudden she's baking cakes, and I'm saying, gee, maybe you need psychotherapy. I'd have never expected that you do something this crazy. So we're all doing things we never did before. But I think we're finding new ways to relate to each other, even if it's virtually, which is a positive aspect. There's tremendous altruism, which, you know, normally watching the 6 or 7 o'clock news is, I call it murders and apartment fires and high-speed chases. You're now seeing a lot of stories of people helping other people out. Isn't that nice? Could that stay on this news permanently? I'd like to think so. You'd like to think there'd be some long-term effect. You'd like to think that if people are wearing a mask at the grocery store now, we would all start wearing masks more often, not to go in there and pretend we're going to hold people up for the toilet paper, but because it's the right thing to do. You know, my wife is fond of saying that we have watched people from Asia for years on airplanes or in airports, and they're walking around in masks. And we almost smirk like, oh, that's overkill. That's a little over the top. She reminded me that their vision of wearing the mask is to not keep from getting sick. Their vision of wearing the mask is to keep from other people getting sick. Think about that. What a paradigm shift that is. So that could be a positive aspect. If we see people wearing masks, we see it as a sign of respect for their fellow humans, rather than some hyper sensitivity paranoia, which is how we sort of used to look at it. I certainly have appreciated through this crisis, as I'm sure many of you have, this has definitely dialed up the humor levels. We're all getting videos. We're all getting cartoons. We're getting some really funny things. And some of them might be a little off the mark. One of the funniest ones I saw was literally a photo of a gentleman's club in Texas. And they had a billboard out front and it said it's closed until the 1st of May. I thought that was pretty cute. So if it's bringing out some humor and if it's allowing us to maybe laugh, if it's giving us some time to sit back and reflect what's really important in our lives and our health and with our families, I guess that's one of those happy side effects of this. You know, there's a lot of books written about optimism and pessimism. Humans tend, and by the way, there's, I'm trying to remember the name of the book. I'll think of it in a minute. Anyway, in life, you can look at the bright spots or you can look at the dark spots. Human nature happens to be that we naturally gravitate toward the dark spots first. If you think about that a minute, there's some of us who are endless optimists. They only see the positive thing, almost to the point of being a little Pollyannish. But most of us, we've dealt with enough bad news in our lives, and we try to run whether it's our jobs or our companies, to be in an anticipatory mode. You have to think of the worst that could happen and how you're going to deal with it. The problem with that is that you get habituated to always be looking at the worst that could happen, right? But there is an exercise that says, why don't you focus, even if it feels a little unnatural, on what the bright spots are? You can always go back to the dark spots, but sometimes it's actually a little more work to look at the bright spots first. And it's not our natural tendency as humans. That's what I got out of this book about looking at the bright spots versus the dark spots. And I'll find myself going down a dark hole and saying, you better go back to those bright spots and get everything back in perspective. So hopefully we talk about the hidden benefits of this epidemic. There are some out there. We all know that it could, you have to dance, you're going to pay the piper. You're talking about a $2 and $3 billion bailout. It's pretty hard to imagine that that's ever going to be repaid without significantly higher taxes. And there are those of us who believe that we ought to be having higher taxes and spread the wealth, and those of us who feel that we worked hard for what we got and we were happy to do our part as long as the money is well spent. All that's out the window. I mean, you get a $2 trillion add to the deficit, it's going to have to be paid back some way, because otherwise all our kids are going to have to deal with this. And I don't think we really want to kick the can down the road for people we love. For our businesses, I think certainly in our business, we are learning that we could operate remotely much better than I ever expected us to do. It's making us do research and learning what we would have never done before of, well, how do you monitor a workforce working remotely? How do you assure accountability, productivity, client satisfaction? And so that's been a good learning experience for us. I mean, we came out of this even making jokes that we have a 6,000 square foot office, saying, too bad there's 2 years on our lease. Maybe we should just keep doing this and go down to a 3,000 square foot office or a 2,000 square foot office. Isn't going to happen right away. But we're all thinking about new paradigms, new opportunities, new possibilities. When this started, I just saw a question pop up about telehealth. This is another interesting learning opportunity. And we all know the old expression, you get what you incentivize. Telehealth has been knocking around for years. Part of the problem is that it has not been valued in, I'd say, an equivalent or rational way in the healthcare system. And we have what's called a supply side healthcare system by and large. I don't know if everyone knows what I mean when I say supply side versus demand side, but basically the more you do, the more you get paid, right? If you have a referral agency, you don't get paid unless you get more referrals. If you have a home health agency, you don't get paid unless you have more cases, a bigger census or a hospice, right? On the other hand, even mixed into home health and hospice is some population health incentives, such as OASIS scores, 60-day case rates for hospice per diems, as opposed to line item charges. Well, telehealth, nobody was paying for telehealth, so it became almost a boutique service. Then you saw the world turn upside down overnight when President Trump says Medicare is going to pay the same for telehealth services, televideo services that they're paying for face-to-face. All of a sudden, there was a mad scramble toward telehealth, particularly when they waived the exemptions and said, you don't have to use a secure platform in the short term. You can use platforms like FaceTime or Skype. I think there's a Google one too. I'm trying to remember the name of it. We knew we had to do this because we had patients refusing visits. We had clinicians who said, what am I going to do to make a living? I don't have anybody I can see. And we said, well, the government will pay for it. We stood up non-secure telehealth in 2.5 days in our group. And here's another hidden benefit of this pandemic. I don't know if you have the same issues in your companies that we have in ours, is that you have a lot of good ideas, you have a lot of projects going. They tend to linger on. It's like glacial pace on getting some of these things done. Well, we proved to ourselves during this pandemic that we could stand up telehealth and start it working in 2.5 days, okay? Now we have a significant number of televideo visits that are occurring, and which is helping our clinicians and helping us. We also know that we're going to need to migrate to a secure platform, and we have clients demanding a secure platform, and we have a secure platform in our EHR. More complicated, more moving parts, yes. Not only that, but the EHR vendor, which is one of the biggest in the country, had so much demand for their integrated televideo module, they stood up 40,000 new televideo modules in 2 weeks. Now, if you don't think that's going to create some learning curves and some operating glitches, I don't know what will. And we were a part of that herd. And yet we started out thinking, oh, this will never work. Our older patients are so technology challenged, they'll never be able to do this. And as we kept testing and working through it, we learned ways to maximize the chances that the call would occur, that the video connection would be secure. If it was interrupted, how to get back online. And we're working with our vendor in what we call a root cause analysis exercise to take them back the problems we're having so they can compare that with all the problems everyone else is having. And they're moving faster than ever to make this thing user-friendly and secure. So are there some hidden benefits of this pandemic? Am I working too hard to look at bright spots? Maybe. But you know, you do what you can do. You know, one of my favorite phrases is, you have to play the hand of cards you were dealt, right? And I've said that many times to patients who have, in a compassionate way, to patients who have really bad things happen to them. And we all encounter those patients that they're under a dark cloud. They couldn't have any more sequential things happen to. We had one patient that we just talked about, whose mother died after she'd cared for her for years, and she was adjusting to that, and then she was diagnosed herself with metastatic breast cancer. Now that's a bad hand of cards. This all happened within a year, okay? And we all have those really sad and heartbreaking stories. I could go on talking about this because if you haven't figured out, I have some fairly strong feelings about what's beset us, what it has as implications for ourselves individually, for our careers, for our companies, for our patients, for society, for our economy, for the world. I mean, let's not get too grandiose here. But the point is, there's a lot to talk about. The dialogue will continue. If we were going to do this again 2 or 3 weeks from now, it could be an entirely different presentation. You realize that? That's how fast things are moving. So I want to stop here. I know there are some questions. One question I saw a glimpse about the telehealth, and the answer is yes, we have stood up the telehealth. We watched our success rate. We're tracking our success rate for successful connections, our number of visits in terms of a dashboard, and we're projecting out the increase in telehealth visits and how it will affect our workforce. We had to furlough part of our staff, not all of them, and how we're going to bring them out and the budgetary implications and cash flow implications of doing that. Does these sound like some of your common business challenges? Of course they do, because we all have the same thing. Business is business, money is money, profit and loss is profit and loss, cash flow is cash flow. So we've tried to make the most out of this. It's been stressful on us, just as like it's been stressful on you. And we expect there to be more challenges in the future. The amazing and gratifying things is how people in our company have pulled together, how our clinicians have acknowledged that this is not our fault and that we're doing our best to take care of them, how our patients have acknowledged that. I hope you're having the same experience with whoever your stakeholder groups are. Our clients have been pleased. We're doing tele-wellness visits, which is part of the reason we need a secure platform. And we elected, not we're dictated to, we elected to build in questions about coronavirus into a tele-wellness visit that's not otherwise normally a part of the tele-wellness visit, because we felt that we might be the only clinical person some of these patients touch, right, over this pandemic. And why not ask them, are you using safety precautions? Are you social distancing? Do you have any signs of illness? How are you doing with social isolation? Are you having depression, anxiety, marital conflict? We had a patient that told one of our clinicians or staff that she could not get food. Think about that. I mean, so if you don't ask, you're never going to know, right? So we figured this is an opportunity to ask. We may be the only person touching them. So I'm sure all of you are doing things like that that are innovative, that are above and beyond. So that's the good news. It's bringing out the innovator in all of us. It's bringing out the humanity. in all of us.
Right,
I'm
so,
going to stop there and let you guys ask some questions.
all right. So, well, my first question is like now with this situation, how everything is evolving, and we have a lot of seniors that are at home, and basically in our case and other cases, other home care companies and other people that work with the elderly at home. What's the process to refer to you, like to reach out to your group?
Okay, I'll give you the a reasonably short answer to that. There's always some nuances. First of all, you can call us that you have a patient that needs to be seen. I would certainly pre-vet with the patient or family of whether
Yes.
they're interested and willing to receive house calls, because just giving us a phone number, we call them, we might get a "who the hell are you" kind of response. The second thing is Medicare is obviously the easiest pathway to refer to us because we can accept all those Medicare patients. If they're managed care, it starts getting quite a bit trickier. You can refer them to us. It depends on the client, because we have some clients that say, well, if they're our patient and they're homebound and we didn't know it, and it's the right thing for the patient, well, of course, we're going to authorize this. We have other clients that their philosophy is sort of what I'd call a primary care physician empowerment, which is the office-based doctor. And we will sometimes advise patients that you need to go to your doctor and tell them you need some home care, not in a disingenuous way, but maybe the doctor doesn't fully realize it. And then the doctor can request a managed care network to allow the patient to get some home care. The other thing, it can be temporary and not permanent. We've had a couple of networks that were worried because, you know, a lot of their primary care docs have either been heroes, kept their offices open, have been heroes and remained as available as they can with either telephonic or televideo visits, which should happen. And we have some that have been less available, and the patients kind of up a creek because they don't know where to go when they have a relatively routine and temporary problem, when they would normally just get in a taxi or maybe even the car and go see their doctor. We're getting some referrals saying, could you please go see this patient, even if it's only one time, because we can't get them into a PCP office. That's not been a broad pattern, but if that's happening, if it's an anecdotal and not life-threatening problem, you know, we're not here to be an emergency room. We're not here to be an urgent care clinic. But if somebody has a rash, if somebody has chronic burning of their urine and they need some intervention, we can certainly do that in short term. Most of our care in our group, most of our care is either chronic care, permanently access, I call it access challenged rather than homebound patients. And I think you can all appreciate the difference. But if you have a patient that's access challenged, if they're homebound, if they can't get in to see their doctor and they would like to have a resource, then absolutely, at least let us talk to them. We have very good screening staff at the office that do admissions and can determine whether our services are appropriate for them. Does that kind of answer your question?
Yes, definitely. All right, so let's move on, everybody. If you have a question, I'm going to move up to general view, so that way. Okay, who has a question? Unmute yourself and let's ask the question. Also, if you have a question too, you can type on the chat too, so that we can see. Anybody, any questions?
I have one.
Okay, who is this? Go ahead.
This is Rick. Dr. Vinn, if you're caring for a patient and then they opt for hospice, are you able to continue as the physician of record, or do you or your practice have to relinquish to the hospice company's physician?
We can absolutely continue as the physician of record. Sometimes the family wants to use the hospice medical director and not us, and that's their personal prerogative. Sometimes the hospice wants to use their own medical director, and that's kind of between them and the family. But we generally offer them the option to have one of our doctors remain as the attending physician.
I think that's great. That's wonderful.
Yeah, we have a substantial part of our practice that is hospice related.
Okay,
It's
great.
sad when you have to change doctors just because of that decision.
Well, you are absolutely correct. And I don't want to gore anybody's ox. But one of the other things we run into, which is not the topic of our discussion today, is that there are palliative care programs out there.
Love it.
And we are strong believers in palliative care. It's within our continuum of care. And sometimes we're a little mystified when a patient needs more of a palliative approach to their care. And this is more with managed care, obviously. They get taken off of our service, moved into a palliative care program to do the same things we were doing already, other than adding in some nursing and occasional home health aides. So if they need palliative care, we consider that part of our job. And if it's a client that they need, that they've subcontracted with a different company, we will respect that. But I think we have to acknowledge that there is a change of relationships there and a change of clinician. And you're spot on, Rick. These patients, they get used to a clinician in a group. They trust them, they rely on them, and they don't deal well with change all the time.
I believe in that. It's a tough decision.
All right, great. Okay, anybody else? Any other question? It looks like Derek has a question. Derek?
So my question is, if we wanted to make a referral to you for house call doctors, would we just call the office directly? Do we call Lily? Who do we call out if we want to make a referral to house call doctors?
Well, I can see Lily on the screen, but I know that there is a direct number into our, if you call our main number, I feel like now I'm on the mypillow.com throwing a phone number at you. But yeah, it's 949-366-1053. That's our main number. And there's a queue there if you want to become a patient. Now, all you have to do is push the button. But you can also always call Lily. I know Lily has run interference here with finding out about somebody that needs services and getting them connected with our admissions department so that they can be screened for their insurance and their location and that sort of thing.
I have a question for the doctor. This is Dory with Home Instead Senior Care.
Go ahead.
Same question I asked the doctor earlier this week. Is your opinion that we are under-reporting at this point? Do you expect the numbers to change and our response to change because of that?
Well, you know, that's a question and an answer that cuts both ways. I think we're absolutely under-reporting because we don't have enough testing, like drive-through testing for anybody that wants it, okay? And the other thing is we're learning on a regular basis that what we thought were the original common manifestations of the disease actually have a much more diverse pattern. You know, we started out, well, do you have a fever? Do you have a cough? Does it have trouble when you breathe? Sounded like it was a cookie cutter. Well, now we're finding out, for example, that people are losing sense of taste and smell. My clinician that got sick lost her taste and smell. She didn't feel all that bad, and she didn't have a cough. She had some aches. So, of course, we're going to underreport when people think, well, I lost my taste, sense, and smell. I don't have coronavirus, right? You know, we don't want to turn into an entirely paranoid society, but unless we get where we can do, you know, 100,000 tests a day, we're going to underreport this thing. And in fact, there are going to be a lot of people, quite frankly, that are going to get symptoms and they're not going to want to tell anybody about it. They're embarrassed. They're worried about their social implications. They may just quarantine, say, I'm staying at home. I'm not feeling well. 2 weeks later, they feel better and they're done. Okay. Because this does have mild manifestations in a lot of people. I don't think we're underreporting seriously ill patients because they can't help but seek medical care. Are we missing a lot of people that are probably under the radar with mild symptoms? I can't imagine. It would be very unlikely that that is not the case. Does that answer your question?
Yes, thank you.
All right,
Yeah, I
Pam,
saw another hand raised.
Pam,
Go ahead.
Pam McNeil, do you have a question?
Hi, and this might be kind of basic, but Doctor, this new drug that you just mentioned, remdesivir or something like that, and the other medications that we hear about every single day, are they a preventative medicine or are they a cure, or is there something to take in advance so we don't perhaps get it, or is there something, or are these that we're talking about to cure the condition?
Keep in mind that, I'm not a public health expert, but I've been watching for a lot of things, and I have heard nothing about anything that you can take that would lower your risk. Hand washing, social distancing, that's about all I've heard, just the same thing you've heard. And believe me, I'd be recommending that if I knew about it.
Thank you.
By the way, I see that Mike King has a surfboard in the background.
San Diego.
There you go.
Mike,
Okay.
do you have a question?
Unmute.
You call me Dr. Vinn.
That's all right.
Days I can't use it. But,
that's true.
No, I don't have a question. I just thank you very much for inviting me. This has been great. It's really very informative. I appreciate it.
All right, thanks.
Another question for Dr. Vinn. This is Derek with Alliance Elder Care. In regards to placement, do you have the ability to test a patient going into a board and care or assisted living for COVID-19? And have that be part of the 602A? That way they don't have to be isolated when they get in as long as they test negative. A lot of places are a little more about bringing new patients into a community.
That is a really outstanding question, but as usual, when you peel the layers of the onion, it gets a lot more complex. Number one, it's unlikely that that's going to be a public health mandate right away, maybe 3 or 4 months from now, but I just don't see the government moving that fast. It could be a facility by facility requirement, complicated by the fact that what I just said, we're still at the point where you can't just go down and ask for a test, okay? It's not there yet, and I wish it was. And then let me add a third layer there, that just because you test negative today doesn't mean you'll test negative tomorrow. That's a really troubling problem, okay? What if you could do an antibody test and say, I've already had it, okay? Well, now I'm hearing things that even in the antibody tests, they're still not sure that you can never get it again, right? Keep in mind, people get flu vaccines every year, right? It isn't like you got the flu last year and you're not going to get the flu this year. So really, until we get an annual vaccine and definitive treatments, we're going to have to be adapting our lives. And at some point, those pre-tests may be available. They may facilitate a move-in. They make people feel better about what's going on in terms of moving in. Is it an absolute proof that they won't bring coronavirus to that facility? I can't say that. Does that answer your question?
It most definitely does. Thank you so much, Doctor.
All right, Doctor, in your professional opinion, what do you think about the people that are protesting at this point? They're out in the street without masks, without anything. What's your opinion on that?
Everything in life is nuanced, right? It's not as simple as it seems. One of the things I really didn't bring up on here, because again, I'm sure it would unleash many different perspectives and opinions, is the political implications of this whole pandemic and how, sadly, it doesn't take long for it to be politicized on all corners of the spectrum. I'm not saying two sides, all corners, because those corners are complicated.
Yes.
You got and you got communities that are doing appropriate sheltering and social distancing, and you have communities that any rational person would seem like this is a little bit over the top, okay? I'm going to relate a personal example, even though I'm respecting it. Mike, he's got his surfboard in the background there, and he's saying, I can't go to the beach. Well, I haven't heard the coronavirus can live in salt water, number one. I rarely see surfers get closer than 6 feet to each other, whether it's on the beach or in the water. And yet they've closed the beaches. But why did they close the beaches? They closed the beaches because of pictures in Fort Lauderdale with a bunch of people in bikinis and board shorts rubbing up against each other at beach bars. Okay, so there was a big protest, as I understand it, I wasn't there, big protest in my town the other day about the beaches being closed and social distancing. So protests, I think it depends on where you are and what's going on. I heard something, my wife is from Michigan, and I heard something like the governor there says, if you live on a lake, you can paddle around in a canoe, but you can't go out in your speedboat. How is a speedboat more dangerous? Unless you have 8 people on it, I suppose. But the point is, some of the protests, you got people that are desperate. Did you see those scenes on TV of people waiting 3 hours in line to get into a food bank, and they got to the front of the line and they were out of food? You're going to see some protesting people. They can't work.
Oh, yes, of course.
It's not just about hanging out at the park here. Okay. And yet you've seen, Smithfield just closed their pork processing plant in Iowa because they had 200 cases there. That's going to affect all of us. I don't need to go on the street about protesting that I can't get bacon. Okay. But I can see that there are some legitimate protests out there in certain circumstances. On the other hand, is there somebody on the sidelines fomenting that process that protest so it could be politicized? You bet. Some of that's going on too. So it all depends.
Okay.
Thing has been politicized already, and it's going to continue.
Oh, yes.
Yeah, election year.
Okay. One more thing. So there's a recent in the news right now, last couple of days, the skilled nursing facility now has over 70 cases in Huntington Beach. So what can we do? Well, mainly the skilled nursing facilities, and also us as professionals and the senior care industry to mitigate these issues. So,
that's been a very disturbing phenomenon, but it really tells you how incredibly infectious this virus is in close quarters. What's interesting, I have a friend that does a lot of work with the homeless, and he's pointed out that the people that stay on the street have a very low rate of infection, but the people where everybody's killing them with kindness and giving them shelters to go into, they have a higher incidence of infection. Think about that, where no good deed goes unpunished, right? And so in the skilled nursing facilities, you have a lot of people in close proximity. You have caregivers moving around, taking care of the same patients, right? They have low resistance, right?
Yes.
It couldn't be more of a perfect storm. You have the assisted living facilities. I think we have some representatives on the phone. They're terrified that phenomenon is going to happen there. At least there, people can stay mostly isolated in their rooms unless they're in a dementia unit, and they can be brought their meals, because we do a lot of work in those facilities. When you get it where you have 2 and 3 people in a room and the same caregiver changing them, bathing them, it's not anybody's fault. It's just a fact of the proximity and the frailty, that it's a super high risk population in super close proximity. I heard from one of my kids, actually, so I'm sure this is a totally reliable source, that they did some tracking of a lot of the kids from Texas that went to spring break in Florida, and they went home and they could track nidus of infection from those individual kids getting home from Florida, where they were all exposed to each other in close proximity. I don't know what's going to happen. I'm sure you saw in the news a facility in Riverside where the staff refused to come to work.
Yes.
They had to move all the patients out of there. Where are they going to move them? There's nowhere to hide here. Yeah. This is a sad thing. Just keep in mind, I've read I'm interested in history, and there's two past pandemics that I find of particular interest. Both what is the same with those pandemics and what's different. You may have read that in the 1918 Spanish flu, which, by the way, if you've seen the documentary, did not originate in Spain. It may have originated in burning manure piles in Kansas, sweeping over a nearby army base, okay? That killed 100 million people worldwide.
Wow.
The good news is we're nowhere near that. We have a lot better medical care now. We have at least antibiotics to treat secondary infections. We have ventilators. There were no ventilators then. Okay, we have ICUs. There were no ICUs then. If you really want to get nervous, read a book called The Distant Mirror by Barbara Tuchman, which is the story of the 14th century, which is the story of the plague, Black Plague, sweeping through Europe. Back then, there was incredible ignorance. They did not know it came from rats. They had incidences when a family member would show up with the lesions. The rest of the family would just get up and walk out of the house and never come back. Just leave them there to die. This book is scary, but the point is, we're doing a lot better than that. Have we solved the problem of a bunch of frail, elderly, chronic comorbidity patients in a nursing home being susceptible because of close proximity and high mortality rate? No. We don't have people getting up and walking out of their houses and abandoning their family members. So it's all relative.
Yeah.
Okay, one more question. So how long do you think do we have to continue this social isolation?
Well, once again, you're watching some of the same things I'm watching. I think this high idea of a phased reopening is probably what we're going to see, because there's tremendous pressure on a legitimate basis to reopen our economy. We can't just keep our economy closed for a year. We'll be overrun by another totalitarian regime who will just figure we're sitting ducks here, right?
Exactly.
We got to recover from this. So there's going to be some very tough and politicized, manipulated trade-offs, okay? I think you're going to see communities where the rate of new infections, the rate of deaths are dropping. And that's going to kind of cross lines with the pressure to reopen. You're already seeing things on TV. Well, a restaurant can reopen, but with plexiglass screens and half the number of clients. What if a restaurant can't break even unless they have 3/4 of their expected number of clients? What good does it do them if they open up with half their clients? So this is going to be all over the map. It's going to be a free-for-all in answer to your question. In terms of degrees of social distancing, this article, this summary I got from this gentleman at the CDC, which is now nearly 6-7 weeks old, suggested that we would need to be in some degree of social isolation until July. Okay. Now, I don't want anybody to go and take that comment and go running to all their sources and BFFs and say, Dr. Vinn said that we're going to be in social isolation until July, because I do not believe that. What I do believe is we're probably going to see this sort of tapering pattern of slow opening under pressure of selected businesses, expanding, the definition of either essential to permitted services. We're going to see decreased volume. Remember, we're going to see restaurants open, even if they could be 3/4 full. There's so many people unemployed that nobody can afford to eat out. Okay, so you got to figure that too.
Yes.
I think we're going to see the beaches reopen. I've seen some golf courses reopen because people are far apart. The whole issue with rock concerts and sports leagues, huge problem. We can see that even canceled through the fall. I'm not predicting it. I'm just saying, when you talk about comorbidities, susceptibilities, and crowding, I think a lot of the reopening is going to be built around opportunities where there doesn't have to be hypercrowding, okay, and close proximity. That's just a general guideline. Other than that, I have no damn idea. But I do think that this complete lockdown deal, I'll be impressed if that ends in Southern California by May 1st. I think there's a good chance it could end by May 15th, because by then everybody is going to be so sick of sitting at home and baking cakes and drinking too much wine that they're all going to get on board and say, I guess we're going to have to go out and take our chances somewhere. Is that a fair answer without committing too much?
Definitely it is.
Okay, so just don't quote me that we're all going to be closed till July.
Oh, well, you're on video, so I'm just kidding.
I know. I'm sure there'll be some manipulated online soundbite here that I'll regret for years.
I have
Okay.
a question for Dr.
yeah.
Vinn, if I could ask one.
Sure, go ahead.
Sure.
Most of us, it sounds like on the call, are either like in marketing or sales in some way. Can you share with us maybe ways that you have enjoyed being approached by different kind of representatives from companies as a healthcare provider? Like, we want to be sensitive. Some of our healthcare providers are slammed, like infectious disease doctors, pulmonologists, where maybe case managers aren't quite as busy right now. Like, how would you recommend that we, contact and approach our doctors to let you guys know how much we appreciate everything you guys are doing, being on the front lines, that we are available, that we are working from home, but not be like overly intrusive, but still like supportive and appreciative?
Well, I think you actually answered your own question. If you can balance out being supportive and appreciative and not intrusive and appearing, just I'm here about a sale, okay? I mean, I make calls like that. You guys make calls like that. We're here to develop a relationship and close and determine us, do sorts of referrals. But right now, I think it depends on the doctor. Remember, people are not only consumed with the clinical demands, they're consumed with all of this planning that's changing from day to day. I don't have a lot of time to talk to anybody about business opportunities. I mean, I still have a few conversations that may have long-term ramifications or may have been intermittent episodes of ongoing conversations. But I'm not typical because we're still out there in the field and we're trying to see patients. But I can tell you, in terms of having available time, I got zilch, okay? I mean, I was very honored and glad to be able to do this call today. And, I'm happy to sit here talking about our company and how you could refer to us and how you could take care of your clients. I don't think that's center stage right now. I think all of you are out there dealing the same stuff our company is: how to cope, how to survive, how to live to fight another day, right? How to pick up the pieces and come back together when things start opening up again. What this all means, how to find some bright spots in what we're doing. And so I think if you just reach out to the people that you have some existing relationships, being honest, I'd love to get some business from you, but I know now it's not the time to talk about it. I just want you to know I'm thinking about you. I want you to know that I appreciate what you're doing, whether you're putting yourselves in harm's way or remaining available to treat patients even by telehealth. I think they'll really appreciate that, and that will pay off in the long run about legitimizing and elevating your status and credibility with them when we are in an environment where you can do more aggressive outreach. Is that a fair answer?
Yeah, that's great. Thank you so much.
All right, great. One more question, anybody else? I guess not. All right, well, thank you, Dr. Vinn. Anything else that you'd like to add?
Well, I just want to say, again, look for the bright spots. Never waste a good crisis. See what you can come out of this if you're a company owner or a company employee. And let's, I don't want to sound like Rodney King of why can't we all get along? But, I think we should be looking for what we can bring out of this thing that may have some lasting resilience in our society and our models of care. I can tell you, I didn't really say it this way. I said we stood up telehealth. I think the genie is out of the bottle. I think we're into a permanent hybridized face-to-face and telehealth model. It's going to be hard to shut that down now that horse is out of the barn. It's affecting my business. I don't know how much it's going to affect your business per se, but you may be doing telehealth, even if you're of a home health agency or a hospice. You may be doing more telehealth with families, okay, or with patients in between visits. Think about what it's going to do to your business model and your operating model and your clinical model down the line. That's one of my closing thoughts.
Okay, great. Well, thank you very much. All right, everybody, have a wonderful day. Thank you very much, Dr. Vinn. If you have any questions, please reach out to me. You got my email. Also, I'm going to be listing all the events and the happy hours and all the events in the industry as well in my newsletter and on our Facebook page.
And thank you again for allowing me the opportunity to spend some time with you.
Of course,
All of
anytime. You're one of the main doctors in Orange County, so of course we got to reach out to you. So
my pleasure.
Dr. Vinn, thank you very much for your time. This has been great.
Thank you.
You bet. And remember, you go till you no can go. That's my surfing phrase. All right, I'll talk to you later. Or as I say with my more cynical friends, keep the stoke until you croak.
There you go.
Hey, that's a good one. Okay, repeat that one again, doctor.
Keep the stoke until you croak.